Okay, so we're going to, in the interest of keeping us on time, we're going to pivot to talk about the system and design elements of the system. So our next panel, they could take their place in the front, Molly, Randall, and Rahul, are going to talk to us about identifying design elements of successful models. So I think it's actually the last conversation, David's points, John's summary, in our group discussion around the mapping of system characteristics, system elements, and different segments of the population is a great transition into this one. You've got their bios, and we're going to start with Molly, and then go to Randy, and then Rahul.
It just disappeared. It just disappeared from the screen. Ah, okay. Okay, good afternoon. So we're shifting now to talk about what is actually going on out there. And I have to confess, are you hearing me all right? I have to confess that I probably did risk exaggerating the proportion of all provider systems that are actually doing this kind of work. But that's a symptom of how fragmented delivery systems in the country are, because I can know dozens of health systems that are working on this, and it still doesn't cover enough of the population. However, it does cover enough of the population to suggest that for most delivery systems, if they really want to start addressing the problem of high-need, high-cost populations, that the lack of existing validated segmentation approaches is not a significant barrier. Now, that's not to say that having better segmentation approaches won't be a tremendous help and couldn't even conceivably be a driver, but it hasn't stopped people from trying to do it, well or poorly. So with regard to current successful models, I'd start by saying that as I went through the extensive, 240-page reading materials, which was a great assemblage, that we risk ignoring a very important tailwind, as someone remarked that Arnie Milstein would call it, that there's a huge tailwind here in some very large not-for-profit delivery systems, and even more in commercial Medicare Advantage plans, what are often called commercial ACO plans, like some that Anthem or other health plans have, and Medicaid managed care plans that are driven not only to improve cost and access, care and access for high-need patients, but to drive down costs. Some examples of those would include what Craig presented this morning about CareMore. At UCLA, we do I was the Chief Innovation Officer at UCLA until last July. And at UCLA, we had developed what's called a commercial ACO with Anthem, where we very successfully addressed complex chronic care patients working with Anthem. This last spring, we did a challenge in the Catholic Hospital Association, which represents about 20% of the hospitals in the country. And the challenge included programs that address superutilizers and complex patients. And we had at least two major delivery systems, Catholic Health Innovation, it's not innovations, I always say innovations for anything with an I, initiatives, and also Ascension Health had very large multi-market, in some cases multi-state programs that were very successful in addressing the populations that we're concerned about. Like Anthem, Aetna, full disclosure, it's in my bio, I'm on the board of Aetna, but Aetna and many other, Cigna, other health plans, Humana notably, have very successful plans in this area. And today I'm going to use two examples, one nonprofit and the other for-profit, to describe some of what's going on in the successful elements. In general, however, if you ask most health systems today that are working on programs for high-cost, high-risk, high-need individuals, they would say that they're targeting them either by age group combined with broad combinations of diagnoses, not very often just single diagnosis, and they're going after high utilizers and hotspotter programs. And so they think of themselves as launching programs that are much more broadly described than are usually mentioned here. They're either dealing with the pediatric population, and the advanced medical home is the particularly well-known version there. Complex chronic programs for adults, which includes some advancing illness, and some of that gets included in the home and community-based palliative care programs, and then the superutilizer and hotspotter programs. So I thought it was particularly useful listening to all three of the presentations in terms of Ashisha's presentation and Jerry's and then Melinda's about what would be the practical consequences if we went to these programs and said, here are what we might suggest as sort of practical approaches based on a review of what is known. I think all of them would welcome that kind of approach and be very interested, but also have some interesting observations to contribute. Now, if we go, however, to the two examples that I wanted to use today, let me give you a little background. Mission Point is a system that belongs to Ascension, which is the largest not-for-profit health system in the country. This program goes into each market and stands up the program and begins to realize savings and improvements in access within 1 year. As of July 2015, they were managing approximately 200,000 patients of the type that we're targeting in 7 Midwestern and Southern markets. Their commercial results, meaning for people who were covered by commercial employer plans, their readmits were down 45% and ED utilization down 24%, total cost per member down 7.2% over 24 months. Medicare and MSSP populations showed very little change in ED utilization, but their readmits were down 9% and total cost per member per year down 5.7%. These are over 2-year periods. For Medicaid, and here specifically it came from work with TennCare, their costs were down 5.7% in the first year and continuing to trend down. Their care system, as you can see here, was a very clear global financing model so that they could really use the resources as they needed to for their patients. This allowed personalized responses to patient needs, iterative learning, and shifts of resource. This is a big problem for us as researchers because they change the model whenever they learn enough to tell them that they ought to change the model, so they won't hold still for the kind of research we would usually do. There's a clear leadership commitment by organization. It's a part of their P&L, and it's a major part of their strategy, not an add-on, nice-to-have little research project. This is a core part of their strategy. There are substantial workforce role changes. As a matter of fact, their teams for these projects are comprised principally of Masters of Social Work, licensed professional counselors, behavioral health specialists, and pastoral care representatives. They explicitly reverse the priority of clinical issues, and they say so in all their writings. This is very similar to what Craig Samet presented this morning about a new approach to segmentation that is based on the need, the felt and expressed needs by the family and caregivers, rather than the clinical approach to a determination of needs. They also have 24/7 availability of knowledgeable staff with personal knowledge of them, their family, their home, and build trust and confidence, integration of behavioral health services, and integration of very broadly defined social services, including housing, help with financing, etc. ChenMed, as another approach, is a for-profit that began in Miami and is now in more than 40 locations in 6 states and spreading very rapidly. They are a pure managed care, Medicare Advantage model. As early as 2012, and you can find this in a Health Affairs, oh my goodness, okay, in a Health Affairs article, they had hospital days per thousand that were 62% of the national average, even though they were operating in Miami, which is above the 90th percentile for the country. And they are a hospital-free model, meaning that it is a pure medical group model. initially staff and now spreading to a network model so they can move more rapidly into other communities. But they are not owned or operated by a delivery system, which is a fairly big difference. So I would suggest among our efforts, we should be looking at successful models out there, whether they're for-profit or not-for-profit, that have taken on large populations, shown impressive savings. The Mathematica study that was cited, I don't think it's the one you're going to talk about today, but the one in our readings that had successfully reduced readmissions did not consistently find savings. And the next study should start with actual savings. Let's start with the systems that really have found huge savings. So unfortunately, I thought that you would think at my age I would be able to judge the relationship between number of slides and amount of time I'm going to take to talk about something. The rest of my slides will be in here, but I'd like to skip to the second to last very quickly. The element that is not in any of the listing of critical elements is technology, health information and services, remote management, and decision support for care managers. Those are increasingly important element in successful models. So I would suggest we include that. I have a list of the barriers here that policy might address. And fundamentally, I would say that we need to follow the idea of let's get some segmentation models, let's get the policy changes out there. We have seen this work again and again be sustainable and continue to build the kind of changes. We know what to do. We haven't given really meaningful incentives to health systems, and only beginning to for health plans. So with that very truncated part of a presentation, thank you very much.